So once upon a time, most physicians thought in terms of dimensions of illness. Hippocrates developed the theory of the four humors and how they influence the body. They were blood, yellow bile, black bile, and phlegm. And various illnesses and mental disorders were thought to be the result of too much of one and not enough of another. If they were out of balance, you'd get sick. But eventually it was realized that certain illnesses are completely different from other illnesses and have completely different causes. Mumps, for example, is caused by the mumps virus. An amazing coincidence that, eh? Chickenpox is caused by the varicella zoster virus. Completely different thing. Both of them can cause some of the same symptoms, like fever, but they're completely different diseases. The job of someone treating them is to tease them apart. What have you got? Fever. Well, that could be any of 100 different things. What else? A skin rash. That rules out most of them. What kind of rash? Oh, like this, and so on. So medical diagnosis was to a great extent about taking the constellation of symptoms, any one of which could indicate a variety of things, and seeing how the precise set of symptoms indicates one disease or a completely different one that might have a different treatment. You've got a sore throat. Okay, let's do some tests. If it's a strep infection, an antibiotic will probably help. If it's cold virus, antibiotics won't do anything. The diagnosis not only tells us which illness a person has, it tells us what to do about it. So this works great if we're talking about this kind of categorical illness. Either you have it or you don't. It's either mumps or it's not. Different illnesses are in completely separate boxes, and we're trying to figure out which box you're in. But there are other problems that are more dimensional in nature. People don't either have it or not. They might have a little bit of it, a little more, or a whole lot. And everybody might be on that dimension. Beyond a certain point, we might say, hang on, that's having a real impact on the person's life. Let's call that a disorder. Everybody, for example, has some degree of insulin resistance. But if you've got more than, say, this much, we'll start calling it prediabetes. Lately, we've changed the way we've been talking about autism. We used to think about Asperger's syndrome as being related to autism, but distinct from it. More recently, we've been talking about an autism spectrum, with some people having a very severe form, and the people we used to say had Asperger's having a milder version. And we talk about whether a person is on the spectrum. And this works, but in a sense, we're all on the spectrum. It's just that most of us are bunched up way at one end. I do workshops for mental health professionals about self-care. One of the topics I discuss is burnout. People think, am I burned out or not? I try to get rid of this split, this dichotomy. I point out that burnout is a continuum, and so, of course, you're already on it. You've been on it all your life, and you always will be on it. Some of us a little more, some of us a little less, and we are all in motion along this line. So rather than asking, am I burned out? I encourage people to ask themselves where they are on that continuum, or, if you like, on that spectrum, and if they're moving toward the really burned out end or away from it. Don't wait to cross the imaginary line before you start doing something about it. So both depression and anxiety are like this. They are not like the mumps. Do you have it or not? We all have some degree of depressive symptomatology. We all have anxiety. The question is, how much do we have, and is it impairing our life to an unusual degree? This is a bell curve, or a frequency distribution. A few people are way down here with very, very few and very mild symptoms of depression. Most people are somewhere in the middle, but some people are way up here. And in fact, the usual bell curve doesn't really show us an accurate picture here. The right-hand end, with people who have a lot of depression, stretches out a long way. Some of us have almost no symptoms, some of us have a few, that's most of us, and some of us have a huge amount at huge intensity. So where's the disorder? At what point do we call it an illness? It would be great if we had a blood test that would make the call for us. Look, this person has the depression virus. No wonder they have so many symptoms. They have the illness. But there is no such blood test, at least not yet. And I suspect we're not going to get one because depression is closer to Hippocrates' idea than to the virus model. It's dimensional, not categorical. It's on a continuum. I don't think it's too much black bile that's doing it, but I do think it's a tendency within humans that can get out of hand and migrate down to the far end of the continuum. So let's zoom in on that depressed end of the distribution. Where do we draw the line? It's really a judgment call. Beyond here, or here, or here, we'll call it a disorder. What the makers of the Diagnostic and Statistical Manual of Mental Disorders do is convene meetings where essentially they argue it out, and eventually they arrive at a consensus. Okay, look, we know this is artificial. We know that in reality people can have a little depression or a little more or a lot, but we're going to split the continuum. Below here, we'll say that people don't have major depressive disorder. And above here, we'll say that they do. It's always a bit artificial when you take a problem that sits on a continuum and you turn it into a dichotomy. It's a kind of useful fiction. Now hang on a minute. People are going to start yelling at me. Did I just say that depression doesn't exist? That it's a fictional diagnosis? Well, if I did, I just wasted a few decades of my life because I've been treating it all that time. Depression is real. People really do experience it. Some of them are hospitalized. There is no doubt in my mind that there is something we can call depression. And there are points where it seems to turn a corner and become more than just a more intense version of what other people experience. But fundamentally, there aren't obvious dividing lines that cut off diagnosable from what we call subclinical depression. So depression may not be the result of too much black bile in your system, but Hippocrates was probably in the right ballpark. Rather than seeing depression as a yes or no issue, like mumps or strep throat, a categorical issue, it really more closely resembles a dimensional issue, like height or weight or insulin resistance. And what this means is that asking a yes or no question about it is always a bit artificial. So, is he clinically depressed or is he not? It's an artificial line that in itself has relatively little validity. A point more on the depression scale might mean you can be diagnosed. A point less might mean you can't. But the treatment approach I'm likely to use doesn't differ that much based on that line call. It's not based on the yes or no question. It's based more on the complex nature of the person's experience and the risk factors that seem to be operating in this particular person's case. The diagnosis often just isn't that useful. You can get How to Be Miserable from your local bookseller or from Amazon. The link's below.